Hello, I am John Gumbs, PharmD, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's CMEOCast episode, Team-Based Strategies to Address Patients' Pain Needs. I am pleased to be moderating this discussion. I'm the Associate Dean for Clinical and Administrative Affairs and Professor of Pharmacy and Medicine in the College of Pharmacy at the University of Florida in Gainesville. I'd like to welcome my colleague, Carol Matichka, who is the Assistant Dean for the Jacksonville campus of the University of Florida. Carol is Campus Director and Clinical Associate Professor at UF Jacksonville. Carol brings a wealth of experience from her work in the retail pharmacy level, as well as academia. Welcome, Carol.
Thank you, John.
To frame today's episode, let's start by reviewing our learning objective. Our first objective is to develop strategies to promote improved communication with the entire pain management treatment team. We also want to look at our role as pharmacists in educating patients about their pain to optimize safe and effective multimodal treatment plans. Carol, I think we would all agree that team-based care is the absolute best approach to managing patients with pain, or for all patients for that matter, but it's not always easy. What are some of the obstacles that get in the way of that goal?
Thanks, John. That's a good question. There's definitely some challenges that we face, not only when we work collaboratively with other healthcare providers, but also when we're providing patient care. I just want to say that, first of all, stigma is such a huge issue when we talk about treating our patients with pain, particularly stigma that's associated with the possible addiction that can occur. So when, for instance, a patient comes to pick up a prescription from the pharmacy, they might be asked very personal questions, and some patients might find that alarming or taken aback by that. But some of the things I think patients should keep in mind is that it is the pharmacist's responsibility to, first of all, make sure that the prescription is valid, and that when they're coming in with that opioid prescription, they're wanting to make sure that that patient is safe. But they also have to look out for the safety of patients in the public as well, just in our community and others who might get a hold of it. So these are some of the reasons that pharmacists will be asking some of those questions. We certainly want to keep an eye on our patients. We don't want them to struggle with addiction, as we've seen so many have this happen to them. And really, it's our duty to ensure that the dosages are appropriate, particularly when we're looking at opioid-naive patients or patients who haven't been on opioids before, and making sure that there's not a risk of overdose if possible. So really, having frank and open conversations with a pharmacist is so extremely important to make sure that medication is utilized properly. And really, just getting to know your pharmacist, I tell all patients, just trying to make sure that they get to know their pharmacist as well as they possibly can. But there's other obstacles as well. Certainly, barriers that pharmacists come across is lack of time. Pharmacists are extremely busy, and it can be very challenging in the pharmacy to really get to know some of their patients as they would like. I think that's improving, but it has been a challenge. There's also a variety of variability in regards to role expectations, not only by the patient and what they expect from their pharmacist, but other providers. And then lastly, sometimes there's this lack of collaboration that can occur between healthcare professionals at any level, but I think particularly when we talk about the community pharmacist, that can be even more challenging because they're not working side by side necessarily with that clinician, and it's often a phone call that they have to make to a local provider to speak with them.
Great insight, Carol. I think you would agree that it's all about relationships.
Absolutely.
It's the relationship between the pharmacist and the clinician. It's the relationship between the pharmacist and the patient. And oftentimes the pharmacist, as part of that healthcare team, can close the loop and provide valuable information in both directions, both to the clinician as well as the patient.
Absolutely.
So, Carol, in the current world of opioid crisis, we hear a lot about an acronym referred to as PDMP. And we now know that in some states, PDMP monitoring is a responsibility that is mandated and can possibly lead to adversarial relationships. It's part of the practice of pharmacists. If something is discovered as part of PDMP, what is the responsibility as a pharmacist to communicate with the provider, whether it be a physician, nurse practitioner, or physician assistant?
So PDMPs, as you said, or prescription drug monitoring programs, are now actually available in 49 states. Not every state, though, requires practitioners to use them, which really creates, I think, some of the challenges. But they can really provide some real-time information and history regarding controlled substance use, such as our opioids like we're talking about. And it really gives some useful data to screen for patients who maybe are doctor shopping, perhaps are using multiple pharmacies, perhaps their dose is escalating too quickly, or perhaps they're getting regimens that just seem very illogical. So these are all things that you can look at within that PDMP, and they might indicate misuse or diversion, not always. And I say might because you want to make sure that you have the entire picture and recognize that if there's a possible problem here and possible opioid use disorder. So once you've gathered that information, this is where it's very important then to be able to communicate that back with the provider. And communication, like we've been saying all along, is key in how you actually provide that information. But it is the responsibility of the pharmacist to provide that information back, particularly in states where it's not mandated for the provider necessarily to look into the PDMP, and perhaps they just didn't get a chance to do that at that time. So it's extremely important for that to take place. It can really ultimately reduce overdose death, is what we're seeing.
Excellent information. I think we all agree that PDMPs are an important part of the overall process, and in some cases they have been game changers to identify possible overuse. But I think we also have to keep in mind that it's just one piece of a larger puzzle, and so all providers, pharmacists, physicians, nurses, physician assistants, etc., should always keep PDMP in mind as just one piece of a larger evaluation of the patient. So Carol, what are some practices we as pharmacists can implement to improve the communication with the providers that we work with?
It really is about communication. Communication is so important. And so when you're giving another provider information, really stick to the fact and give them all the facts that you have. You really want the assessment to come together with each other. You don't want to make that assessment or an assumption right up front. You may not have all of the pieces of the puzzle that they have. They might have more information. So you don't want to jump to conclusions. So first and foremost, I always say stick to the facts and come up with an assessment together if possible. Also, I think another thing that can really help is getting to know your providers that are in your area. So you might have several prescribers, and maybe there are some who do write for a lot of opioids. Well, stop in, come talk to those providers. You know, that makes it so much easier when you have to make that phone call to them so that you can have that open line of communication. Another thing is if you're able to offer education to providers in your area, letting them know perhaps if you're able to dispense naloxone without a prescription, just giving them that information is really important so that they know you're there as an education provider, not only for them, but for their patients as well. And then I always like to say, if you can educate the community, this goes a very long way, just in regards to the patients being able to understand what pharmacists can do, but also providers, because oftentimes they have children in the schools or communities as well, and seeing those pharmacists there and recognizing what they're able to do, and that ultimately we all have our patient safety first in mind.
Great tips, Carol. Basically presenting yourself as a resource, right, to the provider as well as to the patient. I think that's really what it's all about, is just making sure they know that you're there.
Right, absolutely.
So, Carol, education, I think we can all agree, is very important across the board to address this particular crisis. And we have the benefit of a recent report released by CMS entitled Task Force Report Pain Management Best Practices, Interagency Task Force Report Updates, Gaps, Inconsistencies, and Recommendations. Can you give us a little insight and some of your thoughts on this report?
You know, we have a pretty good understanding of the pain process, what causes pain, but we still really struggle with the fact that pain is still somewhat subjective. It's a somewhat subjective affliction. And this is really why education is so unbelievably important, not only for the patient, but for the individual who's providing patient care as well. And so just having frank discussions with patients about their pain, what they can do to alleviate it, while also minimizing any risks that they have associated with treatment. This can really help everyone in creating the best treatment care plan for that individual. You know, there's so many alternatives to opioids, and those really need to be explored and discussed, and figuring out what's most comfortable for the patient can certainly take place if you really look at all the aspects and educate properly.
Carol, when we talk about improving communication, an opportunity may be in the services we can provide to physicians, nurses, nurse practitioners, and physician assistants. You've alluded to some of these issues earlier, but I'd like to pick your brain a little bit more and ask if you could talk a little bit more about the services that pharmacists can offer.
Yeah, great question. So there's lots of ways that pharmacists can provide their expertise to other healthcare providers. One of them is just educating their patients and discussing naloxone as well as safe storage of opioids as well as disposal. And then certainly providing alternative pain medication or treatment recommendations, providing education to the providers regarding opioids in general. And then we have pain management specialty pharmacists who do work in clinics alongside providers. They help manage patients. They help in the decision making regarding prescribing, monitoring, and even managing chronic and acute pain. We're seeing the pharmacists continually evolve in this arena, as well as if patients do end up with some type of opioid use disorder, pharmacists are working there alongside other providers as well to help with the patient care plan.
I think more than any other situation that I can think of currently, the opioid crisis epitomizes the benefit of the healthcare team approach. So using a pharmacist, again, as that resource can be not only integral, but invaluable to a provider's practice and being able to deliver that high-quality care to the patient.
I absolutely agree.
So, Carol, let's talk a little bit about that patient. Patients are an important part of the team. Sometimes we overlook that. What can we do to better educate patients about their pain management?
I think the first thing that I'd say is use the same pharmacy. Use them for all of your medications if you can. We talk a lot about communication and having that relationship with your healthcare provider, and certainly the pharmacist should be one of those. And so maintaining a good relationship with them will help in order to receive the best care. And so then you can work with the pharmacist to explore various non-pharmacological treatment options that might help potentially alongside with whatever opioid the patient may be taking, but that could help potentially reduce the doses for that individual. And then other adjuvant therapies that might be beneficial, and these might be pharmacological in nature, those can also help in controlling chronic. And then making sure that the pharmacist has a complete list of all medications that the patient's on, including their OTC drugs, including any herbal medications. All of these have a potential to interact, or perhaps they're on an opioid that has a combination product in it, such as acetaminophen. And so knowing what else they're taking over the counter as well is extremely important. And then lastly, just if the patient is on an opioid, making sure that they're able to discuss any of the risks and benefits of their opioid therapy, perhaps looking at whether or not there's a possibility they might be able to taper down, and knowing that naloxone is available for individuals.
Yeah, excellent points, Carol. And I think I'd like to tie back into something that you mentioned earlier around the importance of many of these patients using the same pharmacy. Because if patients use the same pharmacy, the pharmacist is much better equipped to identify potential drug-drug interactions, some of which may actually be antagonistic against their pain medication, and that might facilitate higher dosages or add-on medications for pain that could potentially be avoided as long as the pharmacist has all the information they need to identify those potential interactions.
Yes, absolutely. Good points, John.
So, Carol, often we see patients who are prescribed opioids for an acute injury, dental procedure, or minor surgery. A lot of professional organizations, orthopedic surgeons, dentists, and oral surgeons, OBGYNs, are releasing guidelines about opioid use and recommending OTC options like acetaminophen and nonsteroidal anti-inflammatory drugs like ibuprofen as an effective option to opioids. Do you think the data support these recommendations?
Yes, I absolutely do. And I really feel like providing alternative recommendations for pain relief should be considered for every patient in every situation if possible. There's a lot of procedures such as total hip replacement that we certainly need some opioids. But when we look at the length of time that individuals are provided those opioids, even in these specific situations, this should really be taken into consideration. You know, I took a group of pharmacy students overseas, and we went to a few countries in Europe, and we're really taking a look at their healthcare system and how they were treating patients. And I think one of the most surprising things the students learned over there was that opioids are used extremely sparingly. So for even a total hip replacement, patients would receive maybe 2 or 3 days worth of opioids, and then they were quickly switched to Tylenol. They told us one of the reasons is they want to make sure that the patients can tell them if their pain's not improving or if something else is wrong. That's certainly an important component of pain. It's telling your body if there's something else going on. And so I think taking that into consideration with every single patient is how much should I give them and how long should I give them these opioids for is very important.
Yeah, I was actually staggered recently when I saw data on the percent of opioid consumption that is specifically due to the U.S. population as a function of worldwide opioid use. The U.S. is by far the leader in opioid consumption, and I think that's part of the overall problem in changing this crisis and turning it around.
Right. I mean, we use over 80% of the opioids worldwide just in the U.S. And of course, we don't account for 80% of the world. So it's pretty staggering.
Exactly. So, Carol, there are patients with chronic pain well managed on opioids. Following release of the CDC guideline for prescribing opioids for chronic pain, some patients faced stigma, dismissal from practices, inability to refill their prescriptions. In April of this year, the authors of the guidelines published an article in the New England Journal of Medicine about the unintended consequences of the guideline. Can you tell us a little bit about the article and ways we as pharmacists can work with patients in a non-stigmatizing manner?
Yeah, I think that's the biggest challenge because ultimately, right, we just want to take care of our patients and we don't want to harm them with opioids, but we also don't want to harm them in regards to the potentials from pulling them off too quickly as well. I've seen firsthand, heard many accounts and the challenges that patients have encountered from some of the legislation we put in place here in Florida. And so patients are suddenly seeing their doses just cut in half or denied medications completely. And oftentimes this is done without tapering, which of course causes a huge issue in regards to patients with withdrawal symptoms. So then patients, what they end up doing potentially is utilizing illicit substances. So we're seeing patients who are finding heroin or fentanyl derivatives and using that to help with not only withdrawal symptoms, but ultimately helping with some of their pain as well, because oftentimes these patients still have pain that they need to have treated. And so we need to find that happy medium. We need to make sure that we're, especially as pharmacists, what we can do is look for patients who seem to be suddenly cut off from their prescription or not being tapered down appropriately and really prevent any possible issue with a new substance that could occur and reach out to the providers and explain some of the consequences that can occur from happening. So I think if we all work together and make sure that we're not just stigmatizing patients and assuming the worst, we really do want to treat our patients. And so remembering that is super important.
Excellent points, Carol. I was recently made aware of a population of patients in our UF health system that I was previously not aware of. And those are the patients that were originally diagnosed with a malignant disease, sent to medical oncology, were placed on opioids appropriately as a function of their cancer, then through treatment with the oncologist were put into long-term remission. And these are patients then that unfortunately suffered neuropathic pain residual, primarily from the treatment modalities that they were given for their cancer treatment. They were no longer malignant patients, so they fell into the bucket that we began calling non-malignant pain patients. Unfortunately, they continued to be seen by oncologists who were not necessarily trained in chronic pain management. And when they tried to send those patients back to their primary care physician, their return was blocked by the primary care physician who was not interested in managing chronic pain patients on opioids. So we're now developing a pocket of patients in our healthcare systems that were originally treated appropriately, but now have no home where they can go to have their chronic pain managed appropriately. And I think that's an issue that needs to be addressed across all of our healthcare institutions.
Yeah, I completely agree.
So, Carol, there are data that indicate that sources for opioids for non-medical use are friends and family. One important area of education that pharmacists can provide is around diversion and appropriate disposal of unused medication. What are some important things patients should know about this?
So we often think of illicit drug use occurring when somebody buys a prescription or an illegal substance from somebody else. But actually, the majority of the misuse that we see, particularly with opioids, occurs when patients are given opioids from a friend or family, or when they just take it right out of somebody's medication cabinet. And this is also, unfortunately, the most common way that we see adolescents who are getting a hold of opioids. And so it's really important that they are stored appropriately. I always say don't store it in the medicine cabinet. Find a lockbox or somewhere that you know is secure, that nobody can get to, and place them in there. Very important. And then once you're not utilizing those opioids anymore, or you're done with them, I think what happens is we often decide to just put them away and save them for a rainy day in case I get hurt again, etc. And we really need to make sure that we're just disposing of those medications. So there's multiple ways in which somebody can dispose of their opioids appropriately. First and foremost, we do have various take-back programs that are available, and somebody can actually go to takebackmymeds.com and they can find additional details for where those meds can go within their community. They can dispose of them in the household trash. I know that that can be a little challenging in my mind because I still have concerns about that. And when I say put it in the trash, not just take the bottle and throw it in. You pull out the pills and mix them in something like used kitty litter or used coffee grounds, something of that nature, something that people wouldn't want to dig in. But I more so recommend that for people who are wanting to dispose of something that's non-opioid. So if you do have an opioid, my best recommendation is actually to get some of these prescription disposal bags that are available. And you can pick them up at the pharmacies. One of the brand names is called Datura. And when you put the pills in there and you introduce it with all of the contents and mix it around, it actually neutralizes the opioids, and then they can be safely disposed of in the trash. So those are some options. And for those of you who may not be aware, some pharmacies actually have disposal boxes, if you will, for where people can put those opioids as well. No questions asked. They're located typically outside the prescription area. So that's also another option.
Yeah, those are some great practical tips, Carol. Thank you. This has been a great discussion. Let's close with our SMART goals: specific, measurable, attainable, relevant, and timely. What should pharmacists listening today take away from this podcast?
So I think first and foremost, we all need to find ways to help curb the opioid problem in our own community. One of the ways pharmacists can do this is they could actually become a pain specialist or an opioid use disorder specialist and work side by side with other clinicians. But for those of us who work in community pharmacy, really just educating our patients, educating our community, and educating the physicians and those who are prescribing them is extremely important. And you can improve the communication that you have with other providers in your area by some of the ways that I suggested before. And then finally, I can't say this enough, but treating patients in a non-biased manner and not having any kind of stigma associated with them will really help make sure that they're getting the treatment that they need, seeking alternative treatment options from you when possible. And then you're better able to look for signs of misuse and provide that patient with support.
Yeah, great points, Carol. And I would simply add to pharmacists listening, embrace the opportunity. This is a healthcare team approach that is really a second opportunity to none that many other pharmacists will have on a day-to-day basis. There's a tremendous need. Pharmacists are expertly educated to be able to be a key element of the team. And I would just put my plea out there to pharmacists to please step up and take the opportunity to not only help your providers, but also help your patients. So, Carol, I want to thank you for your time today. Your insight, your valuable information has been wonderful, and I know it will be a true asset to those pharmacists listening today. Thank you very much.